next session, that is treatment-resistant hypertension across heart failure phenotypes. To present the topic as a speaker, we have Dr. Soumitra Roy, a renowned consultant interventional cardiologist, Dr. Shantoki De, consultant nephrologist, Dr. Kaushik Dash, one of the senior-most consultant physician, and Dr. B.P. Pandey, senior-most interventional cardiologist and one of the founder member of HDS. Sir and Chairperson, please come.
Thank you, friends. I'll invite Dr. Soumitra Roy. He'll be presenting on a very interesting topic. We see heart failure patients day in and day out. If they have uncontrollable blood pressure, how to manage resistant hypertension in patients of heart failure. We'll get a new insight from Dr. Soumitra Roy. Over to Soumitra.
Thank you, respected chairpersons. Thank you, the organizers and delegates over here. It's very difficult nowadays with these days of deluge of academic programs to get some new topic. But somehow interestingly, we have found out a brand new topic which I haven't listened to in my lifetime, I haven't talked to in my lifetime. Perhaps none of you have discussed it in your lifetime. So let's say it is a very specialized topic. We'll take it to other forums as well. So the subject is treatment-resistant hypertension across heart failure phenotypes. We know that hypertension is a common comorbidity in heart failure, particularly preserved ejection fraction. Everybody knows that HEP is associated with hypertension. There's nothing new about it. What about HEP-REF? All of us are more concerned with low blood pressure in HEP-REF patient when you can't give the medicines. We are handicapped by giving the 4 foundational medicines because blood pressure falls. So why are we discussing resistant hypertension in HEP-REF as well? But resistant hypertension is generally defined as a persistently high blood pressure despite that 3 medicines including 1 diuretic. Now in studies of patients without heart failure, resistant hypertension is actually associated with higher adverse cardiovascular event compared with patient without resistant hypertension. That's the whole idea of giving resistant hypertension as a subject because it carries a worse prognosis, but not in a patient population of heart failure. Now less is known about its significance in heart failure patient. That we never discuss, we never find out in any guideline, in any studies even. Data from the Paragon heart failure suggests that in HEP, resistant hypertension may be associated with worse outcome, particularly in hospitalized patients. If we see the Emperor preserved, you will see that hypertension is present in around 90% of patients. So HEP patient, 90% have got hypertension. But it's not mentioned whether they're resistant hypertension or not. It is never mentioned in any trial. So as many as 25% of HEP patients have resistant hypertension. However, the prevalence in HEP-REF and in mid-range or mildly reduced is not known, and whether it confers a prognostic significance, that is also not known. So study has conducted on analysis of resistant hypertension in the Swedish heart failure across the spectrum of heart failure, hypothesizing that factors associated with patient having resistant hypertension and its associated outcome may be different from type of heart failure. And that is the basis of this talk, which is published just 1 month ago in JACC Heart Failure, that apparent treatment-resistant hypertension across the spectrum of heart failure phenotype in Swedish heart failure registry. It is absolutely new insight into this thing. It is a very large nationwide prospective registry. You know, in Sweden, everybody is under some kind of registry. Briefly, from 2000 to 2017, it's a very long study. Patient with heart failure diagnosed by their treating physician, and 2017 onward, patient with ICD heart failure were included. 30% of population with heart failure were included in the study. So it's a very, very representative study, and the findings you can take perhaps as true and reproducible. A number of clinical parameters were collected, and heart failure was defined by ejection fraction below 30, 30 to 40, 40 to 50, and above 50. And what is treatment-resistant hypertension? They have defined 140 systolic or 135 for diabetic patient, despite a RAS blockade, which can be ACE inhibitor, ARB, or sacubitril, as well as a calcium blockade and a diuretic. So standard 3 medicine that we define. Patients were defined as having non-treatment resistant hypertension if systolic blood pressure exceeded this threshold, but the patient was not on 3 combination blood pressure lowering regime. So there may be 2, there may be 1, there may be 3, but with lower doses, and the pressure is not controlled. So they are not treatment resistant by definition. And systolic blood pressure below the target is normal or no hypertension. So there are 3 groups. An alternative definition was, I will not come to that, sometimes as the threshold changes from 2017 or 2018 onwards, that 130 by the American College of Cardiology was the threshold. Now, as we said, the heart failure was defined as 40, 40 to 50, and 50. Now, the results are very interesting. If you see that normal blood pressure in HFrEF patient on your left, 73% are normal blood pressure, but 27% of HFrEF patients have got hypertension. And of this 27%, 10% are treatment-resistant hypertension. This is a new data to all of us. In our HFrEF patient, ejection below 40, around 30% of patients are still hypertensive, and 10% are resistant hypertensive. That is very new, and which is also same for mid-range. But when in HFpEF, obviously around 40% are hypertensive and around 20% are not controlled. And these patients are usually women with short duration of heart failure and long duration of hypertension. Symptoms are milder, they are obese, they have more diabetes, and they have low GFR. Now if you see, this is most interesting. If you go back here also, first heart failure hospitalization or cardiovascular death, if the normal BP is 1, then treatment-resistant hypertension has got no benefit if there is HFpEF. In HFrEF, there is benefit. So look at this. So cumulative incidence of the composite outcome, its component and death. In HFrEF patient, normal BP incidence is highest. If you have got hypertension or resistant hypertension, your event is less. Significantly less. That is a surprising finding. So, in HFrEF patient, do you want your patient to remain hypertensive? Perhaps the answer is yes. So this is very, be in the bonnet. In mid-range, the same. HFpEF is different. Here you have to control the blood pressure. Then you get the benefit. Just the opposite of HFrEF. So they concluded that treatment-resistant hypertension present in 10% of HFrEF patient, 14% in mid-range, and about 20% in HFpEF. Several factors were associated independently, and they were irrespective of ejection fraction. In contrast, the association between resistant hypertension and outcome, that differed widely across the patient's ejection fraction. One thing is clear, irrespective of ejection fraction, a treatment-resistant hypertension was associated with a lower risk of cardiovascular death and all-cause death. Now, I know this is hugely controversial finding, but it's a very authentic finding from a very authentic country like Sweden. Now, there are explanations given as well. So, there are some general observations. Patients with resistant hypertension are more obese, more diabetic, more vascular disease, and more kidney disease. Okay? The present study were consistent with these previously reported differences and were generally similar across the ejection fraction, except ischemic heart disease, that is ischemic cardiomyopathy, was less often associated with resistant hypertension. So ischemic cardiomyopathy patient had less resistant hypertension. Dilated cardiomyopathy patient had more resistant hypertension. Most notably, after adjustment for other potential confounder, high BMI, a low GFR, and diabetes, these three are associated with a higher likelihood of resistance in all heart failure, whether it is HEPREF or HEPF. If you are obese, if you are renal disease, or if you are diabetic, your chance of getting blood pressure uncontrolled is higher. That is perhaps understandable. There is nothing much surprising in it. Kidney disease and diabetes is about half of the patient of resistant hypertension. This is also confounding to normal, our old understanding. This may be because patients with CKD are prone to volume overload, sympathetic overactivity, and arterial stiffness, and they may have suboptimal adherence to the drug. So they may not be true resistant hypertension. That's why the term is apparent treatment resistant hypertension. Moreover, patients with RH are more likely to develop progressive kidney disease. So other way around, in addition to increasing the risk of kidney failure, diabetes may cause resistant hypertension by its own mechanism, by leptin and aldosterone associated obesity. So diabetes can cause resistant hypertension either by renal pathway or non-renal pathway. Conversely, atrial fibrillation and ischemic heart disease were both associated with lower likelihood of resistant hypertension. The association with ischemic heart disease may simply reflect a competing risk. Who is causing heart failure? Whether IHD is causing heart failure or hypertension is causing heart failure. If IHD is causing heart failure, hypertension has got no scope to cause heart failure because the patient is already in heart failure. So patient without an ischemic etiology, hypertension is a likely alternative cause of heart failure. But if ischemia is there, your rejection is 30% because of a large scar, there is no scope for hypertension to be there. Atrial fibrillation may be a marker of more advanced heart failure, and so the blood pressure is already low because of advanced heart failure. So that is also an interesting postulation. Now, specific observation, they say, clinical outcome in patient with treatment-resistant hypertension across the three categories were examined. And in general, patient with a TRH and non-TRH, but not normotensive, had a lower risk of outcome examined compared with patient with normal blood pressure. Now this is very, very funny. In HEPREF, patient with a resistant hypertension were at lower risk than patient with normal blood pressure for all clinical outcomes, consistent with a higher blood pressure in patient with left ventricular systolic dysfunction being a better outcome, as I was telling. In mid-range, it is the same relation, because we now know that mid-range behaves more like HEPREF rather than HEPF. Now what about HEPF? Now HEPF, however, TRH had a similar risk of the composite outcome as normal blood pressure. It's not higher, but at the same time not lower. It's the same risk, cardiovascular death and all-cause death. Whether you are hypertensive, resistant hypertensive, or normotensive, if you have a HEPF, blood pressure does not matter. Hypertension is believed to be a major driver of disease process in HEPF through afterload dependent development of LVH and dysfunction, but it does not confer any difference in prognosis. Furthermore, hypertension or the episode's crisis may cause worsening heart failure, particularly HEPF patient, and thus was not associated with a lower risk of composite outcome. So why it is not lower as HEPREF? Because it can cause some heart failure exacerbation, as we call flash pulmonary edema, exacerbation of edema because of a high incidence of heart failure for 2, 3, 4 days. Patient is on hypertension and he goes into failure if he is already on HEPF. So that might eat away the benefit of hypertension, but still it is at par, not worse prognosis. Now paragon heart failure, where the blood pressure was up to 180, they were taken. Patient with a treatment resistant had a greater risk of primary outcome. Now this is perhaps more consistent with our thought process, that higher the blood pressure, worse the prognosis than normal blood pressure, because of hospitalization of heart failure. But in the TopCat trial, which took up to 160 millimeter blood pressure, rates of primary outcome were same. In the United States particularly. It is not clear why this Paragon and TopCat were different. Maybe the high, maybe 160 to 180 blood pressure is worse, maybe up to 160 it is good, very high blood pressure may be bad, we do not know. Other observational studies like optimized heart failure, they more closely resemble the sweet heart failure, and here there was no difference of resistant hypertension, treated hypertension, and non-hypertensive people, even if you have got a HFpEF. So the perspective is that this study provides comprehensive account of a treatment-resistant hypertension in all three heart failure categories. Prevalence, even in HFrEF, is around 10%, which we are never aware of. And in HFrEF and in mid-range, a hypertension gives some protection, whether per se by pathology or by association of its circumstance. It gives protection, we are not sure. In HFpEF, there is some controversy, but till some amount of high blood pressure or resistant hypertension is not detrimental unless it is very high or severe hypertension. Now, if we come out of this study of sweet heart failure and see in the Emperor Prism, as we was mentioning, around 90% patients were hypertensive, but if you see there is no difference of outcome whether the pressure was below median or above median. So blood pressure really did not differ the prognosis. Even in Emperor Prism trial.
Recording in progress.
Even in HFpEF patients, they're all HFpEF patients. And if you see all the trials which showed the HFpEF, most of them have got high blood pressure, and the Emperor Prism was the only one which gave the benefit. Even in the dapagliflozin trial, if you see, on cardiovascular death or worsening heart failure, systolic blood pressure has got no interaction with the outcome of dapagliflozin. Whether it is low, normal, high, it is no difference of outcome even with dapagliflozin treatment. And if you see the recently, only last month published in ESC, DEPA heart failure and deliver, so all range of heart failure for 15% to 75%. Dapagliflozin is equally effective. There is no interaction depending on ejection fraction. And definitely, this ejection fraction includes all categories of hypertensive patients. Some are low blood pressure, some are normal blood pressure, some are high blood pressure, but there is no interaction of benefit. So again, it proves that blood pressure may not be important in heart failure patients. But if we go at the end of my lecture, what is the current understanding by the ESC guideline? Drug treatment strategy for HFrEF patient, ACE inhibitor or ARB, diuretic, here you can use loop diuretic, and beta blocker. For HFrEF, it is also antihypertensive. And step 2, you add an MRA. In all heart trial, alpha blocker arm was prematurely stopped due to increased heart failure. So alpha blocker you avoid, and here is a very good statement from ESC 2021. Uncontrolled hypertension in patient with HFrEF is rare. Now they might change from the sweet heart failure, it is now 10%. Provided the patient is receiving optimum medical therapy at recommended dose. Because all the 3 drugs of the 4 reduce blood pressure. If further BP lowering is required, in absence of signs of fluid overload, amlodipine and felodipine have been shown to be safe in HFrEF patient. So this is very interesting. We usually don't give amlodipine in HFrEF patient. But if there is no congestion, this is a recommended drug, class 2A. But diltiazem verapamil and centrally acting agent like moxonidine are contraindicated. They exacerbate heart failure. Alpha blockers have no effect on survival and not indicated. They can be used for prostatic hyperplasia, but be very careful. And resistant hypertension is the standard. I won't go, this is not relevant. Therapeutic strategies in hypertensive patient with heart failure or LVH, you have to be careful that, as I mentioned, the medicines given, because no specific drug has been proven its superiority. All major agents can be used in LVH patient. It's better to give a RAS blockade and CCB or diuretic even in stage 2 of hypertension to prevent the stage C heart failure. So I stop over here. I know this is a very controversial subject and I welcome your opinion and your suggestion on this subject. Thank you.
Thank you, Dr. Soumitra. Any questions from the floor? The fact, Soumitra, you mentioned that heart failure reduced EF with good blood pressure has a better prognosis. I think one of the important reasons is that in these group of patients, the guideline mandated therapy can be optimized to a great extent and quite early on, because someone coming with heart failure with blood pressure of 140, I start with the highest doses of the ARNI, the highest doses of the MRAs, highest doses of beta blocker. So you can reach to the target and ultimately the prognosis will be better. I wanted to know if there has been any group analysis like they have from 2010 to 17 and ARNI was introduced in 14 onward. So it will be interesting because now no longer this is the RAS blocker, this is ACE-ARB oblique ARNI, which is not mentioned in the guidelines. So I think there will be some subgroup analysis.
And they showed no interaction between ACE inhibitor and RD. And they have already interchangeably used this and there was no interaction.
Because this is not uncommon. In daily practice, we see heart failure patients coming with high blood pressure. I have already given all the 4 foundational therapies. What else? So you must see the last ESC recommendations. Calcium channel blocker can be used. Stop moxilidine. Stop alpha blocker if there is no pressing indication like prostate. So there are now recommended guidelines how to use and bring down the blood pressure. This is also a fact that heart failure patient, if they are obese, if they are in sinus rhythm, if they have got a higher blood pressure, they do well compared to otherwise. So we have seen in our practice, lean and thin patient, lowest blood pressure, atrial fibrillation with heart failure, they do bad. And another point of what I see in my clinical practice, any patient with heart failure who comes with hypertension or they come with hypertension, if I found ejection fraction low, the first thing should come in your mind is aortoarteritis, which is very prevalent in at least this part of the world. So unless you look for, I saw just 2 days back, high blood pressure, ejection fraction 40, in fact was referred to me for evaluation of aortic valve replacement. Outside echo shows severe aortic regurgitation. With blood pressure very high, I saw that EF is low. I just put a probe on the abdominal aorta. I got a gradient of 90. So she had an obstruction in the mid-aortic level below the subclavian. So the teaching is that heart failure with hypertension, you have to rule out Takayasu arteritis, coarctation, and certain collagen vascular diseases. So these are very different ballgame. Treatment will be different. So it's not an uncommon. Yeah. Question from the back.
Thank you, sir, for the nice deliberation. My question is, in the DAPA heart failure study, they have shown that in people who do not have diabetes may get benefit from dapagliflozin, the SGLT2 inhibitors. Your take on this?
Yeah, of course. Now we don't look at the diabetic status to give dapagliflozin. A heart failure patient, a diagnosed heart failure patient, even you don't need to see the ejection fraction. From 15% injection to 80% injection, you can give dapagliflozin and expect the same benefit as long as your initial diagnosis of heart failure is well established.
So where it is positioned in the treatment guideline?
It is now 2A, now it will be class 1 in November.
Thank you, sir.
One more question. In case of this subgroup of resistant hypertension, which drug do you prefer after the standard 3 drugs?
In which patient?
In this resistant hypertension, in this subgroup, after the first 3 drugs, which is your...
Look, usually we have, my clinical experience is there are 2 types of drug you can use. MRA is very, very effective because there is this primary aldosteronism is not detected, we cannot detect it, our labs are not up to date. So we just give it by assumption and 8 out of 10 cases it works.
And which MRA? Soumitra, now we have got 3 MRAs.
You know that finerenone is not yet there, I don't use it. But eplerenone I usually use if the patient can afford because it's much less side effect. The effect-wise they are same. both the spironolactone and eplerenone, but side effect for eplerenone is less. And number two, if it is that profile of patient, beta blocker works in me. I am a great believer of beta blocker. So it is a younger patient, sympathetic overactivity patient, high heart rate patient, sweating patient, corporate patient who are always anxious. I always give beta blocker and fantastic.
So we can combine the MRI with beta blocker, that would be better.
Absolutely, absolutely.
In fact, for refractory hypertension, the beta blocker is the drug of choice because refractory is because of sympathetic overactivity. So patients not responding to 4 drug, of course.
And actually beta blocker is being researched all over the world. There are loads of papers are coming. I just gave a lecture with international speakers where they showed, ESC showed there are 5 patient group where you give beta blocker. And he showed 51 group of patients where you give beta blocker. So almost nobody is left. And actually I was talking to Dr. Bongsi Sahu and he said, you supply me all the evidence from API, we will publish an upgrade paper on beta blocker for Indian hypertension. I am on the process of that.
Yeah. And we had
upgraded at least for Indian patients.
We had a discussion with Dr. Rajiv Agrawal from USA, nephrologist. Aldactone, spironolactone causes a reduction around 10 to 14 millimeter. Eplerenone around 8 millimeter. Finerenone not more than 4 to 5. And one approved drug in Japan, isoxarenone, is equivalent to spironolactone. So there is a gradient in BP reduction. Spironolactone, isoxarenone is the most potent antihypertensive. And spironolactone action lasts for around 3 weeks, rather than others are very short half-life. So I think in a country like ours, we should give more spironolactone. We have to be watchful for gynecomastia and hyperkalemia, of course. So with that, I'll close this session. Thank you very much, Dr. Soumitra. He's our classmate, a wonderful person and great speaker. Thank you, my coach.
Thank you, speaker. Thank you, chairperson.